Good afternoon, friends. It is a great pleasure to present before you IAOS Rheumatology course module 13. What started as 12 hours of rheumatology course has now expanded to 24 plus hours, and this is the 24th video of the course. This is an ongoing course, and depending on the lectures added, knowledge gained, we will continue to add these lectures for your pleasure, which you can use for lifelong. This lecture features the first topic by none else than Professor Mukharji from Delhi, and the topic is further my refinements in Mukharji regime. And then the next speaker is our own Arvind Divakar Jain, and the talk is very dear to me because it has helped numerous of my patients. Magic bullet for ankylosing spondylosis. Before we start these lectures, I will give a short introduction from my side. We just need to rewind time, go back to 2016, a decade ago, when I was an arthroplasty surgeon, and just that. I had evolved in orthopedics, started with basic arthroplasty, then went into Ilizarov, then went into arthroscopy, then back into primary plasty, then specialized in revision arthroplasty, then super specialized in revising infected arthroplasties. So that was the state of my orthopedic practice in 2017. And I was a very ignorant person with no knowledge. Methotrexate for me was an anti-cancer drug. HCQS for me was an anti-malarial drug. Ankylosing spondylosis was just bamboo spine and reduced chest expansion, fuse hips and fuse knees. If hips are fused, do a THR. If knees are fused, do a TKR. Steroids are something I was really afraid of, and I had seen many Cushingoid bloated patients in my clinic who have been given tons of steroids by general practitioners, and in my practice a decade back, I probably seldom use steroids in my prescription. And despite being in orthopedics for 30 years, I knew nothing about managing rheumatoid arthritis or ankylosing spondylosis. Important thing is, personally, I am never shy of accepting my ignorance. To be stupid is refusing to learn. To be stupid is not being ignorant. Ask once and you are a fool once. Don't ask and you are a fool for life. And then I met Dr. Arvind Divakar, Dr. Arun Mukharji, Dr. Prashant Shah. And by talking to them, discussing with them other things, I realized that during my entire medical education and also my entire life after medical education, what I had learnt was just scratching the surface. I realized that during my entire medical college and also the life thereafter, what I had learnt was not enough, not adequate at all. Endless hours were spent with Divakar, Arup and Prashant over the last 10 decades. I learned how DMARDs work. I learned more about DMARDs, which were demystified for me by Dr. Arup Mukharji. Phenylbutazone, which I remember only with a keyword, aplastic anemia, became a magic bullet. Methotrexate became a wonder drug. I began to understand gut bacteria and I could learn that these tiny microbes inside our intestine were really magical. No matter how much protein you eat, it will not be absorbed as protein unless it has been broken down into amino acids by the gut bacteria, and only then the same can be assimilated into the body. So, gut bacteria, what is gut bacteria? I didn't know anything about it 10 years back. Lot of things had to be learnt, and we learn by unlearning the fixed knowledge that medial pivot knee or computer navigation or AI technology in arthroplasty, which was one field, and going with the body and going naturally was the other field. So once I learned these techniques, my percentage of surgeries decreased. Happiness score of both myself and my patient increased dramatically. Not only that, I could actually connect the common threads between diabetes, dyslipidemia, hypertension, angina pectoris, and myocardial infarction. I came to know the frozen shoulder, ONE, diabetes, it's not angina, it's angina, and all are interconnected. I learned the basics of non-infective inflammation. Non-infective inflammation, which is responsible for so many things and useful for so many people like cosmetologists, diabetologists, rheumatologists, neurologists, orthopedic surgeons. Today, 70% of my patients receive Mukharji regime or its modifications, or one or two of Divakar's wonderful introductions. From this, I will give the mic to the masters. Before they start the talks, I will give a short introduction. Dr. Arup Mukharji is going to talk on his regime and where and how it is useful. This talk was supposed to be a part of Indian Orthopedic Association's annual conference in Guwahati in December, but because of Indigo Air crisis, Dr. Mukharji could not make it to Guwahati. Post conference, I requested him to make a recording which he sent to me, which is attached here. In a similar manner, as Dr. Divakar's flight also was cancelled beyond Delhi and he could not reach Guwahati in time for giving the talk, I had asked him to send me a recording, and that is a part 2. Those of you who have not attended the IAOS Rheumatology course and are seeing this lesson alone are advised to message me at 97910 20615 WhatsApp, and I shall be happy to share the details of the rheumatology course. Thank you very much and have a nice day. Thank you.
Hello friends, I am Dr. Arup Mukharji. I will be talking about the new innovation regarding the management of regarding the management of inflammatory disorders in the body. This talk will be about the use of Mukherjee's regime in managing the most common OPD which patient which we come across, that is arthritis and other inflammatory disorders. So this is about the magic of Mukherjee's regime in correcting the osteoarthritis, spondyloarthritis, ankylosing spondylitis, etc., which we regularly see in our OPD patients. Before I start my talk, I should give my tributes to this great scientific contribution of India to the world. He is Dr. Yallapragada Subbarao, who came from Andhra Pradesh, and he worked in Harvard Medical School, where he invented a number of wonderful drugs which are still relevant and useful to the medical field. What is inflammation? Any tissue suffering from inflammation becomes insulin resistant, so that intracellular metabolic activities become low due to the lack of energy and glucose metabolism, because this insulin resistance does not allow the glucose to enter the cells of the different tissues. So high insulin was previously understood to cause insulin resistance to the tissues and cells. But now we know that there are other factors also which make the tissues insensitive to the glucose, and the glucose does not enter the cell. So these two hurdles are known as inflammation and high steroid level in the blood. I will also pay my respect to my teacher, Professor A.K. Gupta, who was professor and head in orthopedics in Kanpur. And after his retirement, I have been associated with him for many years in order to hone my skills in orthopedics. Now, arthritis patients, now it is known that these arthritis patients have a genetic susceptibility to develop arthritis in later life. But there are many predisposing genes associated with arthritis. But when these people are exposed to tobacco, to air pollution, to alcohol, and recurrent infection, they develop active arthritis in different stages of life or at different age of life. Inflammation of musculoskeletal system causes pain. That is the reason these patients come to our OPD. Other systems affected by inflammation seldom cause pain, but nevertheless cause serious cellular dysfunction or organ dysfunction like brain, gut, liver, and kidneys. Regarding inflammation, three major autoimmune disorders are known. These are arthritis, which is the inflammation of the musculoskeletal system. Second is ulcerative colitis, which is the inflammation in the gut. And third is the bronchial asthma, which is the inflammation in the lungs. So these are the three major autoimmune disorders which create genetic inheritance to the offsprings of the patients who are suffering with these. The minor autoimmune disorders are multiple, which we know as disease, and we know them as lifestyle diseases. But these are inheritable diseases like hypertension, hypothyroidism, diabetes, psoriasis, coronary artery disease, irritable bowel syndrome, PCOD, etc. Skin disorders like eczema, SLE, psoriasis, lupus disorder are also minor autoimmune disorders. We now follow treat to target policy to control rheumatoid arthritis, which is a major autoimmune disorder of musculoskeletal origin. Previously, we observed wait and watch policy and we saw these patients deteriorating with as we kept on our conservative mode of treatment to these patients. These diseases progressively caused more and more joint damage, causing disabilities. These cause related morbidity, allergy, infection, osteoporosis. These caused mortality due to coronary cerebrovascular accidents, coronary artery disease, and peripheral vascular disease. Concept of preclinical rheumatoid arthritis. Many studies have shown that rheumatoid arthritis is a continuation of a pathologic process starting years before the onset of clinical synovitis. In genetically predisposed individuals, environmental factors like smoking, gut dysbiosis, infection, pollution can lead to creation of many antibodies pathognomonic of rheumatoid arthritis. Barbara Corkery is a prominent scientist in USA. She brought the first concept of pre-diabetic stage in the year 2014 in American Diabetic Association Banting lecture, where she said that a diabetic patient is diabetic much before the onset of the clinical picture. That means these patients have prodromal symptoms of diabetes many years before they manifest diabetes. What is Mukherjee's regime? Mukherjee's regime is the use of low dose disease modifying anti-rheumatoid drugs or DMARDs, which are used to control rheumatoid arthritis. So, there are 5 basic drugs which can bring remission in disease activity like rheumatoid arthritis. These 5 basic drugs are Methotrexate, Salazopyrene, HCQS, Lefenamide, and steroid. These are the 5 basic drugs which bring the remission or which controls the acute disease activity of rheumatoid arthritis. This is my 100-day prescription of rheumatoid arthritis, where I have used nearly all the 5 DMARDs associated with probiotic, with vitamin D, with vitamin B12, curcumin, omega 3 fatty acid, CoQ10, calcium, and vitamin E and vitamin C. Why do I use all these medication? Because we all know that a proper dosage of these drug can bring about remission in these patients without causing harm or overdose or side effect medication to these patients. Before starting the regime, we should also see that the blood tests are done, that is CBC, ESR, CRP, sugar fasting, HbA1c, LFT, KFT, lipid profile, TSH, vitamin D levels. We also get a ultrasound of the whole abdomen done before starting the regime. This is this regime is meant for 100 days of treatment. Now what is is it the final? Now this is in short form what Mukherjee regime necessarily means to supplement and prescribe the patient. This is the shortest form of Mukherjee's regime. What is the aim of regime? The aim of the regime is to provide a safe DMARD for a long-term use because the book recommended doses of DMARDs are not safe. There is no concept of vitamin supplementation in the book recommended DMARDs. There is no concept of protein and calcium role in the treatment. There is no consideration of food allergies which happen in different patients. There is no idea of autoantibodies generated against the hormones commonly seen in autoimmune diseases. Why DMARDs are considered safe to practice? Because the therapeutic dose and the toxic dose are close. How safe is Mukherjee's regime? That is a natural question to be asked in a in a scene like this. My patients are on this regime for decades together. This is a follow-up of a 15-year-old seropositive rheumatoid patient who now lives abroad, comes once every year to get the treatment modified according to the latest blood test. So that means this regime is very safe in to practice in patients who are suffering from chronic rheumatoid patients. It is very difficult to convince a senior orthopedic professor that rheumatoid arthritis and osteoarthritis is one and the same, while osteoarthritis is intermittent, less widespread, and less intensive. Rheumatoid arthritis is clinically more aggressive and extensive in patient's body, and multiple organs are affected. This is another example of a 24-year follow-up of a seropositive rheumatoid arthritis with fixed deformities. From bedridden state, she switched to the wheelchair status and then to the ambulatory status of unsupported walking. Now she is independent in her home, living with her children and grandchildren, and she is independent in activities of daily life. But the treatment is still continues, which we can see that she is now walking independently, which wasn't possible before. How safe is Mukherjee's regime? I will show you with these two examples. This young girl who has delivered a child 3 months ago, a normal child 3 months ago, is suffering from seropositive rheumatoid arthritis. She had multiple miscarriages due to lupus. Now I had to continue this treatment through the whole pregnancy and even after pregnancy because her hormonal status was maintained by this regime, and she is practically symptom free in spite of seropositive rheumatoid. And this another woman who she is a seropositive chronic rheumatoid patient. She did not realize when she has got pregnant, although her children were grown up. And then one day she came with an abdominal discomfort and she was subjected to ultrasound examination where it was disclosed that she is 7 months pregnant, and this child was born from this lady, absolutely healthy and normal child. So this is how safe this regime is. These type of patient add to my confidence. This is a patient, young man of ankylosing spondylitis with both the hip fused 6 years down the line. See that the joint space have appeared in both the hip joint. There is a mobility has been regained in these patients, in this patient, and he is nearly normal activities of daily life. This is a patient follow up of 35 years, 1992 to 920, of 33 years, where he was first seen by my teacher, Professor A.K. Gupta, where in those days there were barely any medications available for ankylosing spondylitis. He came and joined to me in 2005 when I started my regime, and now both the hip mobility is maintained, and although there are some fixed deformities in the spine, but he can walk normally, and you can see that he is a retired government officer, and he doesn't want any surgery. His both the hip joints are mobile, he is active, and this is what it looks like. This is a prescription from my teacher in 1992, declaring him as a ankylosing patient, and gradually his joints became progressively stiff, and till I intervened in 2005, started him on my regime. See, these are the advanced cases of arthritis and deformity which are given this regime. But what is the advantage? That they develop full function of the hand and the wrist and are rehabilitated in their daily activities. See this gross varus patient knee who came to me with recurrent knee pain, but because that time he was kept on my regime 20 years ago, since then he was moving with this varus knee for 20 years on my regime. He comes and joins me again, telling that now the pain is getting again and again. So I did an HTO, and you can see him walking. Why HTO? Why not a total knee? Because both the surgery correct the alignment of the hip, knee and ankle joint, but in an HTO we retain the sensitivity of the joint surface. So that is a much acceptable realignment procedure rather than a TKR. This is the same picture of that gentleman who is now walking 6 to 7 kilometers every day, and this is the post-op corrected picture of the patient. This is a knee pain again from a lady who was subjected to TKR, and when she came to me in Delhi, I only did a PFO on the other side and kept this lady on Mukharji's regime, and she was more happy with this as this knee had a sensate joint. The rising rate of failed hip knee surgeries is a concern, as it is said by the experts, because the more and more it is being done in elderly people, more and more are the complication rate like infection, periprosthetic fracture, and osteoporotic fractures. My clinic is full of these elderly people who have never been hospitalized for the last 20 years, and no joint surgeries, only on the regime, so that they are free from the complication of arthritis like pain and spinal stenosis. See, this is a 85-year-old gentleman who has been on my on my regime for the last 20 years, and he's still doing well, and there is no complication of any other associated disability. Let us take up this challenge, that now onwards it is our duty to share the information with our patients that joint replacement is not necessary in osteoarthritis or arthritic pain. It is more important that you correct the metabolic disorder, so that these patients can suffer less from joint pain and be healthy metabolically, and then they can extend their healthy life with full activity with the treatment. Thank you so much. I am again thankful to the listeners to come and hear my talk about Mukherjee's regime and how does it affect their life and their activities in the patients. Thank you so much.
Hi everyone. Now I'll talk about my discovery 50 years back, which saved life of many patients of ankylosing spondylitis. It is no more a dreading disease, and how I killed ankylosing spondylitis I explain. Can we halt and reverse the ankylosing spondylitis? Yes, we can.
क्या है गणेश तुम्हें कौन सी बीमारी है हाँ कितने साल से है
लगभग 2009 से है।
2009 से है यही इलाज खा रहे हो जब से हमारे पास आया तब से ठीक हो
जब से ठीक
और उसके पहले हमारे पास आने के पहले
नहीं थे।
आप पैर छुप के अपने पैर छू छुप के जरा सीधे खड़े हो तुम्हें कमर मोड़ने में कोई प्रॉब्लम नहीं है ना कोई दिक्कत है बस दवाई खाते रहते हो ठीक है दवाई जब तक खाते रहोगे ठीक रहोगे ठीक है चलिए अच्छा है ओके
These are X-rays taken after 16 years, and you can see his freedom. Alternating hip pain in young males, especially early feature of the ankylosing spondylitis. 1% population has ankylosing, mostly males. 80% positive for HLA-B27 compared to 7% in general population. Morning stiffness ease by workout. No lab test diagnostic of AS. ESR, CRP is raised, IgA is raised, and alkaline phosphatase in severe disease, ANA positivity induced by the TNF-alpha blockers. Tuberculosis so commonly coexist, activated by NSAID in endemic countries. Every malaria attack increases severity of AS. So dreadful bamboo spine is enthesitis. Enthesis means ligament in one junction. It is inflamed, swells, and ossifies, which is the cause of the ankylosing spondylitis. Syndesmophyte is a vertical plate seen in diabetic dish, and ankylosing are different from horizontal osteophyte of the spondylosis. Syndesmophyte, annulus fibrosis, and ligamentous ossification, and osteophytes are vertical plates with dysregulation. In AS, stooping forward and front gaze is a spot suspicion. Even anyone can spot a case in a crowd. This disease, autoimmune process associated with HLA-B27 gene, attacks vertebral joints. Collagen gets destroyed, replaced with fibrin, ossification sets in, bamboo spine comes, also affects eyes, aorta, tendons, and lungs. This is modified New York criteria for the diagnosis of AS. We don't consider this useful for India. So I have my own prime suspect criteria for AS in Asian setting. Analgesic used since long or too many consultations. Morning stiffness. Pain eases on activity. Young person begins backache at age 25. This alternating gluteal pain, raised DSR, finger floor distance more than 6 inches, chest expansions less than 2 inches, high fever of unknown origin in young boys. HLA test causal. No, HLA-B27 testing alone is not considered diagnostic for any disease. It is considered a supportive piece of information used in conjunction with clinical symptom and other tests to help diagnose conditions like ankylosing spondylitis, reactive arthritis, and sometimes juvenile rheumatoid arthritis. As a positive result can increase likelihood of these, it doesn't definitely confirm them. A negative result does not rule out the ankylosing either. Signs in a classical case. Your doctor commonly orders blood test to check for the HLA-B27 gene, which is present in most people with the disease. You may have HLA-B27 gene and never develop ankylosing spondylitis. HLA-B27 positive and negative, what difference they have? More prevalent in white patient and patient with AS, earlier disease onset, high family aggregation, high frequency of uveitis, cardiac involvement, hip joint involvement, younger age at onset of inflammatory back pain and more severe radiographic progression, more bilateral fused SIJs, greater responsiveness to TNFs, and negative persons more prevalent in non-white patients and patient with NR-AX SPA, longer diagnostic delay, higher frequency of peripheral arthritis, dactylitis, psoriasis, IBD, lower disease activity, less extensive involvement of the SIJ and spine, less frequent radiographic sacculitis, less symmetry of syndesmophytes. Clinical examination is more important than HLA testing. Clinical exam is more for the sake of recording the progress, and for the diagnostic imaging is the only answer. Lumbar spine side flexion test for spondylosis, chest expansion test for ankylosing spondylitis, tragus to wall test, because with the increase in flexion fixed deformity, the distance from wall to tragus increases, and modify Schauber's test for ankylosing. That means we put a points to the spinous process and ask him to flex the spine. Normally, the distance between 2 points increase, but it doesn't happen in ankylosing. Imaging is criteria summary, posterior oblique or X-ray of the SI joints. It is the best view. Sacral joints in interest is open. Ala of the ilium is not overlapped over sacrum. Optimal exposure factors needed. Another view is axial view, Ferguson. It is a cephalad view. In first X-ray, you can see SI joint is not very clear, but here SI joints come up and it is seen more clearly. And bamboo spine is the undulating contour of the spine caused by bridging syndesmophytes seen in ankylosing spondylitis. And dagger sign, this is my recent case. You can see broken lines of fused posterior interspinous ligament. This is a dagger sign. A single central dense line is a dagger sign. Double line is a railroad sign, and all three lines are trolley truck sign. Romanus lesion is not specific SPA. Romanus lesion, 26% of healthy volunteer also seen. This is also known as shiny corner, shiny bulb sign. Very, very prominent in MRI, but seen in X-ray also. It's a spiral finding in ankylosing spondylitis representing reactive sclerosis secondary to inflammatory erosions of the superior and inferior end plates of the vertebral bodies. Florid spondylodiscitis, a lip-like sign in T1 and T2 images. This is a sign of very, very active disease. Often we miss plantar fasciitis, may be the only presentation. So other signs are fusion, plantar fasciitis, costochondritis, costosternal joint, and uveitis. Textbook of Rheumatic Diseases, first edition. All began when I was preparing my seminar on analytics in 1976, reading this book. Kopman's Textbook of Rheumatology Disease, 1964, butazolidine is the prime example of new generation of drug. At that time, it was a new generation that could often give great relief as demarred in ankylosing sufferers. Mr. Patel, who came from USA for his unrelieved ankylosing in 2019. With Muhammad Khalid, man with a cap, the person on whom all dosing titration are based, as he lives next to my clinic and work at an adjacent medical store. Mr. Patel in middle was due to attend his kid's marriage in Ahmedabad. His USA family physician suggested to use this opportunity to visit me in India, 1200 km from his city. Phenylbutazone is a resurrection of a magic bullet in ankylosing spondylitis. Originally, it was used in Europe as a solvent for injection aminoparin known as brand name Argaparin. We used this Argaparin till 1984 as a common drug like ibuprofen and paracetamol, and nothing happened. But suddenly a government advisory came, this is a toxic drug for the kidney, cytopenia, and drug has been banned. And we feel this is a banned drug, but it is not banned in India, it has never been banned. The Swiss company Geigy first introduced Phenylbutazone in 1949. This drug alters thyroid test. So whenever you are going for thyroid test, tell the doctor you are taking PVZ. A drug that has anti-inflammatory, antipyretic and analgesic activity. It is especially effective in treatment of ankylosing spondylitis. It acts as a DMARD. It is also useful in RN eaters. No more advice for the gout. It was previously drug of choice for the gout as well, as we have better drugs for the gout now. Because many people told that this is a banned drug, why you are using? So we put multiple RTI. One of the RTI replied, Health Ministry has given the answer. Drug is sold and not banned in India. Only combo with the paracetamol is banned. So any combination of paracetamol is not allowed. Warning with methotrexate. Methotrexate and Phenylbutazone, 2 patients with psoriasis was reportedly followed by development of widespread cutaneous ulceration and 1 fatality, following bone marrow depression and septicemia. Although a causal relationship has not been established, this combination of drugs should be used cautiously. Drug warning is stop medication the first sign of gastrointestinal upset, jaundice or blood dyscrasia. Authenticated case of egg gland issues with the drug have occurred in men. Any significant fall in total white cell count, relative decrease in granulocytes, or black Otari stool should be regarded as signal to immediate cessation of therapy.
मेरा नाम मोहम्मद खालिद है। मैं कम से कम 15-20 साल से फिनाइल खा रहा हूँ और मुझे कोई दिक्कत नहीं हो रही है, ना झुकने में ना बैठने में। स्पॉन्डिलाइटिस इस बीमारी से पहले मैं बहुत परेशान था, लेकिन अब काफ़ी अच्छी तरह से चलता हूँ, काफ़ी अच्छी तरह से सारी क्रियाएँ करता हूँ।
अभी तक कुल कितनी गोलियां खाई होंगी आपने पिछले 25 साल में?
लगभग 5 से 7।
आपको कोई परेशानी नहीं है? आपके फैमिली के लोग भी ठीक हैं इस दवाई से?
जी जी
ठीक है।
He is Mr. Mohammad Khalid. He has been experimented all the dosing and everything, every observation, how to relieve the patient. He was even a small child. He presented me with a high recurring fever for 1 year. It was diagnosed typhoid, malaria, whatsoever. It is the X-ray of his brother. He came for the backache. Arose suspicion of AS and I diagnosed, oh, you have fever of ankylosing. And only after treatment, he became all right. X-ray taken after 28 years of disease on PVZ, you can see mild sacroiliitis only. Comments from a doctor in 2018, Dr. Padya, he is the government doctor. Thank you so much for the PVZ. Patient was on Seculimab. Now feeling very happy with the PVZ. He was praying you like more than a god. It took 4 decades to confirm safe and effective regime with PVZ. Stop all drugs except vitamin C. Start PVZ 100 mg TDS for the first 10 days. Remember, in 10 days, plateau is achieved. So the plateau can be maintained with 100 mg OD till relief or ESR returns below 20. Then 100 mg weekly lifelong. Many patients are happy with 100 mg once a month too. There are 2 patients who are on once a month dosing only. Many patients, eye surgeon referred for the backache, comes out as an ankylosing spondylitis associated arthritis. Now I tame this incapacitating illness. Many patients who left my regime as their doctor tells PBZ is banned drug. So they stopped and they fell for it and they fell into the multiple disorders and went for the steroid treatment, passed life horribly, multiple arthroplasties, dead due to amyloidosis. But with our magic bullet, it's simple. Only I have to explain. It is not a cure. It will be given to lifelong. Recommended tests are HLA-B27 allele among North Indians, 2.7 to 29% in North Indian and 0.9 to 2.1% in South Indian. 80% may develop disease. Frequently in AS patient is 74%. CBC repeat on every visit, ESR with HB repeat every month, HLA-B27 once, it is not diagnostic, X-ray of affected parts, MRI spine, coexisting malaria, TB and diabetes, eye exam. Record on each visit, finger flow distance and chest expansion. So my all 800 plus ankylosing patients globally lived a restriction-free life. I consider this God chose me to deliver a smile to ailing humankind. And with the IAOS methods, you will always be a winner. Thank you so much.